Hello everyone! For those of you who may not know, I am Shannon Hoy, and today's conversation is going to be about a specific research article that uses applied behavior analysis theories and interventions with a sample of people who are methadone patients. I chose this article because in my undergraduate years, I co-wrote several theses about the benefits of least harm interventions from a community health practitioner point of view. Therefore, my background offers a perspective that differs from the typical behavior analyst. Anyway, this article, which is entitled Attendance Rates in the Workplace Predict Subsequent Outcomes of Employment-Based Reinforcement of Cocaine Abstinence in Methadone Patients, was written by Wendy Donlin et al. And published by the Journal of Applied Behavior Analysis in 2008. Before I jump into the summarizing and analyzing of the article, I wanted to review a couple terms. The first is the Premack principle, which is also referred to as the if-then principle. It goes like this. If I do this unpreferred activity, then I get to do this preferred activity. If I abstain from cocaine use, then I get a raise. Or then I get to cash in my work voucher. Whatever that person finds reinforcing. With this, a behavior analyst must also understand that with an increase in response effort must also come an increase in reinforcer magnitude. So if I'm asking my client to abstain from cocaine use, the reinforcer must match that. If I say, if you abstain from cocaine use, then you'll get a sticker book, do you think that person is going to abstain from cocaine use? I would hazard a guess that probably not. The response effort for someone who's addicted to cocaine to abstain from it is extremely high, so the magnitude of the reinforcer must also be very high. In the same stroke, if someone were to tell me, a non-cocaine user, that if I were to abstain from cocaine use, then I would receive a sticker book, that would totally work, because the response effort for me to abstain from cocaine use is extremely low. So it would be absolutely ridiculous for someone to come to me and say, Shannon, if you abstain from cocaine use, you'll get a raise. Do we understand? So let's go back to the article. The research required that the participants in the study were at least 18 years old, currently unemployed, enrolled in Baltimore City methadone maintenance programs, cocaine positive urine sample was given at intake, met the APA's criteria for cocaine dependence, currently receiving welfare benefits, and scored at least an 80% on the reading assessment. This may seem awfully specific, but this is how the researchers limit the number of confounding variables that may influence the result in any unaccounted way. The purpose of the study is twofold. The first objective is to determine if attendance during the baseline period, where access to work was independent of cocaine use and the intervention contingencies, could predict the efficacy of the abstinence reinforcement contingency, the treatment. So basically they wanted to see if the treatment worked. The second objective was to replicate a previous study to increase the validity of the association between employment-based reinforcement and an increase in cocaine abstinence. Because we all know that we need multiple studies with the same results to feel confident that the results are what we think they are. The intervention that the researchers were testing was a multi-part treatment package, employing both reinforcement delivery contingent on a negative urinalysis test for cocaine and punishment delivery for a newly positive urinalysis test for cocaine. Participants who had abstained from cocaine use were eligible to work and maintained the maximum stipend of $8 an hour. Participants who did not abstain and had a positive urinalysis result were not allowed to come to work that day, and then upon their return to work, their stipend is decreased to $1 per hour. But with that, every day that they work since then, their stipend increases $1, as long as they remain abstinent. The researchers' analysis shows that the participants' attendance trend obtained during baseline could predict the participants' behavior during treatment. So, in their discussion, Donlin et al. Suggests that the efficacy of an employment-based abstinence reinforcement treatment package could increase if an intervention was first implemented to increase the participants' attendance independent of the urinalysis test results. They suggest that employers could do this by increasing the reinforcement for attendance or changing the type of work to something more interesting to the participant. But I would first ask if they mean increasing the magnitude of the specific reinforcer or increasing the frequency of the delivery of the reinforcer, or both. And I would also question the realistic ability of an employer to alter the type of work for an employee to suit the desires of that employee. As with all interventions I've been a part of, not all interventions are going to work for everyone. For some, it may even have the opposite of the desired effects, and the researchers warn this in their discussion. They caution that if the response effort is too high, the participant may end up significantly decreasing their work attendance or may even stop attending altogether. This, to me, highlights the importance of implementing an attendance intervention before an abstinence intervention. What I really like about this article is that the researchers truly highlight how their research and findings were novel and what it brought to the field. They make the point that there have been many surveys done to various populations, so not only drug abusers, but also children with IDD, and really anyone else who's under a behavior analyst, to identify reinforcers for those individuals. Donlin et al. State, though, that many of those studies rely solely on the self-reported reinforcers from those surveys, as opposed to first evaluating the efficacy of those reinforcers. I remember in my research methods class in undergrad talking about how self-reported data was okay-ish for a starting point when formulating a hypothesis to be tested or for identifying a possible population type, but that it was very much discouraged to use self-reported data for anything more than that because it's riddled with biases and inaccuracies most of the time. So you have to be really careful about that. One limitation of this study that the researchers identify themselves is that there's no control group to compare the results to. My suggestion to the researchers would have been to return to baseline, since they did not have that control group. So, if you're listening to this and you think that you want to replicate this study, either have a control group or return to baseline. It'll increase the strength of your findings. I would also suggest conducting a component analysis. The treatment package uses both positive reinforcement and negative punishment. So I would be curious to see if both needed to be used or if one intervention type is more effective than the other. Now, the question that I've asked myself throughout reading this article, and the one that I'll pose to you, is as a behavior analyst, what do you think the biggest hurdle would be for an employer seeking to generalize these outcomes to his organization that employs people who are substance abusers? Would it be the resources required to conduct such frequent urinalysis tests, the ability to turn away a worker for an entire day, the flexibility to alter the work to accommodate the employee's interests, or something else that you can think of? Because we all know if you can't generalize the outcomes of the research, what's the point? So anyway, thank you so much for watching, and I'll see you next time.